All right, we'll probably go ahead and get started. Thanks everyone for coming today. So today's grand rounds will be given by Dr. Matt Durstenfeld, who is an assistant professor of medicine in residence at the University of California, Los Angeles, and the director of cardiopulmonary exercise testing research in the Division of Cardiology. He completed medical school at the University of Pennsylvania, residency and chief residency at NYU, and cardiology fellowship and a master's in clinical research at UCSF. He joined the faculty at UCSF, where he completed a K-12 Career Development Award on Cardiopulmonary Long COVID. His K-23 Career Development Award from NHLBI is focused on cardiorespiratory fitness in HIV. He leads the CPET Core Lab for NIH-funded studies in HIV, long COVID, and post-TB cardiopulmonary disease. In 2025, he joined the faculty at UCLA. In addition to his research, he also practices clinically as a general cardiologist and echocardiographer at UCLA Ronald Reagan. He has published over 50 peer-reviewed manuscripts and has been recognized as an emerging leader by the World Heart Federation. Thank you so much.
Thank you for the introduction. Since let's see if my slides will advance. Okay, here are my disclosures, mainly my NIH funding. So since I'm new to UCLA, I thought I should provide a little bit of my background. So I grew up here in California, but up in San Jose. As a kid, I loved doing science fair projects. I was definitely a nerd, and my favorite projects were related to rockets. And then I went off to Yale, where I studied biomedical engineering. Then I went to Penn for med school. And one of the highlights of my time during medical school was going to Kenya, where I did a clinical rotation at a Christian missionary hospital that has a huge cardiac surgery referral program. So it was a really amazing opportunity to get to see cardiology and cardiac surgery in a totally different clinical setting. Then I went off to NYU for residency, and I really fell in love with my time in the CCU. Shown here is the first CCU team I had, and then I also did go back to Kenya with my wife, where we did a clinical rotation there as well. While I was in residency, on my first cardiology elective, I asked, what should I do to get into cardiology fellowship? And everyone said, you need to do research. And at the time, I had zero interest in doing research. I thought I wanted to be involved in health systems and in low research settings. And I asked, well, who should I do research with? And everyone said Saul Blecker, who was a young investigator at NYU in health services research. And he asked me, well, what are you interested in? And I said, I'm really interested in disparities, especially seeing the contrast between Bellevue and NYU, which are physically right next to each other and couldn't be more different. And so I led this study on racial and ethnic health disparities, and it was a really great experience. And I didn't have to do any of the data analysis, which I didn't have any idea how to do, but I got to really think about the research question and answer it. Then I returned back to California for a cardiology fellowship, along with my newborn daughter, Lucy. And it was a particularly interesting time to be in cardiology fellowship during the pandemic. And I was really grateful to be back close to my parents, especially for the extra childcare. And then I'll talk a little bit about my research journey. But after finishing fellowship, I joined the faculty at UCSF before coming here. So we're going to go back in time now about 5 years to April 2020. I was about to start my T32 year with Priscilla Shu. And I was supposed to study CHIP and HIV, clonal hematopoiesis, but everything shut down. And we were basically put on a kind of ICU backup rotation. This is the ICU, which was completely full. They opened a whole nother ICU at San Francisco General. And this is where I was assigned to be on service during COVID. A few months later, not that long after, there started being led really by patient advocacy groups, this story of symptoms not kind of getting better, of long, debilitating symptoms after COVID. This article was published in the New York Times in May 2020. And then not that long after that was an editorial by Clyde Yancey and Greg Fonarow, who's here, really asking this question based on what we were seeing in the ICUs, people with really significant RV dysfunction, with LV dysfunction as well, and wondering, is this viral infection going to cause an epidemic of heart failure? So in that context, as I was trying to figure out what I was going to do next, Michael Peluso and Steve Deeks approached Priscilla and asked, is there any interest in having a cardiology part of our study of COVID? And I had nothing better to do and thought it was a really interesting idea. And so I ended up helping lead the study, trying to understand the cardiopulmonary aspects of long COVID. So we started enrolling, we wrote a grant, wrote an IRB, started enrolling people in November of 2020 in this sub-study. And really, we were focused on people who didn't have cardiovascular disease before COVID. And our main outcome, there was no definition of long COVID yet. So we were focused on cardiopulmonary symptoms, chest pain, shortness of breath, and palpitations. And we started with echocardiograms because that was practical. And we had a lot of preliminary data saying they were really abnormal in acute COVID. So here's our population for the first 120 people we enrolled. And the two things that really stood out was a female sex predominance and hospitalization for acute COVID. The more severe your acute COVID was, the more likely you were to have persistent symptoms. As we looked at the echocardiograms, they were basically normal. There's just a small number of people with pericardial effusions. So we found an odds ratio of about 12, but with a pretty wide confidence interval. And then the really interesting part came with the biomarkers, that those with elevated SARS-CoV-2 antibodies, even months after, as well as those with high sensitivity CRP, like evidence of systemic inflammation, those are really the two things that stood out as being associated with symptoms, more so than the echocardiographic findings. So where do we go from there? Well, just because we don't see something on an echo doesn't mean there's not something going on in the heart. So then we created partnerships and found some donor funding to expand the study and add some more advanced cardiac imaging, including cardiac MRI. I'm doing ambulatory heart rhythm monitoring, and what I'm going to talk more about today, cardiopulmonary exercise testing. And I really thought that was going to be the most exciting thing to do. That a lot of the patients, as we enrolled them in the study and talked to them and got to know them, what was really bothering them is that they couldn't do their activities of daily living anymore, that they had really bad symptoms whenever they just walked around or went out to do errands. And so I was really excited about CPET as an opportunity to understand this disease better. So what is cardiopulmonary exercise testing? I don't know how much exposure there is in the fellowship program here, but at UCSF, where I did fellowship, there was minimal exposure to CPET as a fellow. If you wanted to, you could spend a day or half a day on your echo rotation kind of trying to figure out what they were talking about, but there was no formal training. So what it is exercise stress testing, and it can be done with a treadmill or with a bike, but it has measurement of both cardiac parameters, and the key additional feature is measuring pulmonary parameters. Most importantly, measuring gas exchange. So how much oxygen is being consumed, how much carbon dioxide is being produced, and what's the flow of air in and out of the mouth. The reason why this is really interesting is because there's this really tight coupling of what goes in and out of the mouth through the lungs to the heart and blood to the muscles down to the mitochondrial level. So without having to biopsy people or do really invasive things, we can get a sense of what's actually happening at the cellular level. And so that's a really cool way to understand physiology in live people. And the key thing I just want to point out is we're going to talk about VO2 or peak VO2. That's the volume of oxygen. And the idea of this is that the volume of oxygen that we're going to measure as being consumed is going to equal the cardiac output times the cardiac extraction, the oxygen extraction. There are different levels of cardiopulmonary exercise testing. What I'm going to be talking about here today is level 1 or non-invasive CPET. And the real three main things we're measuring with the metabolic cardigan are the flow, the carbon dioxide, and the oxygen. But from those, we can actually get a lot of really interesting derived variables that tell us a lot about the physiology. Just to give a brief touch on some of the important things we can get out of this, clinically, it's used for workup of exertional intolerance or exertional symptoms like dyspnea and fatigue, especially if kind of the preliminary workup comes up negative. If you're not sure if it's HFpEF or pulmonary hypertension or other things, pulmonary disease. And then it's really helpful for quantification of cardiorespiratory fitness and the anaerobic threshold. And this can help with risk stratification for surgery or for advanced therapies. And then it's also really useful for exercise prescriptions for rehabilitation. On a research side, which is where we're focused on here, is it can help us understand the mechanisms of disease or of particular symptoms within a disease. It allows for precise perturbation of physiology. So instead of just measuring someone at rest when they're sitting there, lying there, getting a blood draw, you can really understand what happens when they're put under a very specific, measurable, defined stress. It allows for quantification of functional capacity or cardiorespiratory aerobic capacity and anaerobic threshold. And then it's also useful as an outcome for clinical trials. So before or after treatment, is there a change in functional status? The reason it's really good for that is it has a very high reproducibility. So that makes it very sensitive for within-person change. And it's been an established outcome for pulmonary hypertension and hypertrophic cardiomyopathy trials. Cardiorespiratory fitness is really important because it's strongly linked with outcomes. So in this study that included 93,000 veterans who had 2 or more exercise treadmill tests with a median follow-up of 6 years, you can see this really powerful spectrum of risk depending on your cardiorespiratory fitness. So those with higher levels of fitness have much lower mortality. And this is regardless of whether you have baseline cardiovascular disease or no history of cardiovascular disease. The other variable that I specifically want to highlight is what happens to your heart rate during exercise. In this study from 1999, the chronotropic index, irrespective of your stress test findings on imaging, is a really powerful predictor for mortality, much more powerful even than the fitness part of it, which is also a powerful predictor. So once we did our study in long COVID, we enrolled 60 people, and we found that peak VO2, the basically cardiorespiratory fitness, was lower in the red here among those with symptoms. That's kind of what we anticipated and what we expected to see, but it was nice to actually be able to measure that and quantify it. Now, the really surprising thing was this part about chronotropic incompetence, or the inability to increase your heart rate when you exercise. That's a pretty unusual finding in a clinical stress lab. Usually it's associated with either severe heart failure or with patients who have really severe multivessel coronary disease, which does not describe any of our patients here. And we found about a third of people had chronotropic incompetence. And even when we use a really strict definition requiring people to have both reduced exercise capacity and a low adjusted heart rate reserve, there's this really interesting population of people down here who just don't increase their heart rate when they exercise. Now, this is a really powerful predictor for symptoms with an odds ratio of 18, and then also a powerful predictor of reduced peak VO2 or low cardiorespiratory fitness with an odds ratio of 10. So as we kind of thought about how we could fit this together, this is our kind of conceptual model that SARS-CoV-2 infection leads to immune activation and inflammation. Remember, that's what I showed you with the echo study. It may cause some pericardial effusions, but those are probably a result of the inflammation. They may not be really linked that much to exactly causing the symptoms per se. We also, I'm going to show you a slide in a moment, but we also found some evidence of Epstein-Barr virus reactivation, and that may be linked to this chronotropic incompetence. The infection itself may impact autonomic responses, and together this may help explain why we're observing this low cardiorespiratory fitness and chronotropic incompetence in people with symptoms of long COVID. So, as we thought about what could cause chronotropic incompetence in long COVID, first I just want to show you what this actually looks like. In the yellow here are the people with chronotropic incompetence. On the x-axis here, we have the percent of their predicted peak VO2, so 100%, is normal. There's some range around that, but these are people with reduced exercise capacity. And you notice that their peak heart rate only goes up to about 110, which is profoundly abnormal. And these are mostly, people in their 30s to 50s, otherwise previously healthy, no history of cardiovascular disease, not taking beta blockers. This is a really kind of profound and surprising finding. When we tried to, think through systematically through, could it be in the brain? Could it be in the peripheral autonomic nervous system? Could it be in the sinus node or with heart block? I mentioned that we measured ambulatory heart monitoring on individuals in this same cohort that we did the CPET on. And so this work was led by Chris Hill, who was a medical student at the time, now an internal medicine resident. We really eliminated sinus node dysfunction and heart block as major contributors to that with the ambulatory heart monitoring. And we have this interesting finding that there is this kind of gradient of heart rate variability, which is kind of a marker of autonomic function. And it's related to the balance of parasympathetic and sympathetic tone. So this group in the yellow here is the group that had chronotropic incompetence. They have really marked reduction in their heart rate variability. So not only does their heart rate not increase when they exercise, their heart rate variability moment to moment with breathing is also very low. Again, I mentioned the Epstein-Barr virus part of it. So this big panel on the left here, this is peak VO2, not heart rate, but it looks similar. And then adjusted heart rate reserve down here. You can see that these individuals down here in the bottom left are the same individuals I showed you with the circle previously. These are the people with really profound chronotropic incompetence and really abnormal cardiorespiratory fitness. And many of them have evidence of Epstein-Barr virus reactivation at the time of their acute COVID. Now, severity of COVID is also related to that. The more severe your acute COVID is, the more likely you are to reactivate Epstein-Barr. But this is a really interesting part of the story that needs further investigation. The other thing that's really interesting is this pattern with inflammatory markers. So the higher your inflammatory markers, the lower your peak VO2, and also the lower your heart rate response during exercise. And similarly with the antibodies. So leading from this, we did a small sub-study of individuals with autonomic symptoms within the cohort. That on the left here is their symptom scores. So they have really profound autonomic symptoms shown here in the red, and really notable orthostatic symptoms. So we're trying to find people with POTS. And what you can see here is that the heart rate shown here in the red among the symptomatic individuals is really increased throughout heads-up tilt table testing. But it doesn't have this spike that you would see with POTS. It's just increased all the time. Again, kind of going along with our idea that this could be related to inflammation. So, it would be one thing if it's just our study that showed this, but we then conducted a systematic review and meta-analysis to look at other studies. And really, there were a number of studies that compared individuals with long COVID symptoms and without symptoms. There wasn't a standard definition, so each study used a slightly different definition. But we found this really notable decrease in peak VO2 of about 5 milliliters per kilogram per minute, or about 1.5 mets. And there was a lot of heterogeneity in the studies. Most of them enrolled individuals who are hospitalized with really severe COVID. But there was a lot of different ideas from these studies about what could be contributing to that, not a lot of consistency across the studies. So one of the big questions that comes up is, how much of this is really due to COVID? All of those studies were cross-sectional. They only have data after individuals were infected. Almost all were just at a single time point between 3 months and a year after. And so in order to answer this question, we really need longitudinal data. So I went on a hunt. I tried to reach out to all of the major cohort studies in the US, and really most of them did not have pre-COVID and post-COVID exercise testing, at least that had been completed yet. And then secondly, most of them actually didn't have data on actual long COVID symptoms. The big consortium, C4R, had been adjudicating when people actually had COVID, but they had not yet started or didn't have data on whether people were continuing to have symptoms yet. So then I got connected with the Cooper Clinic, which runs a large kind of executive health type program in Texas. And they have done exercise testing on individuals for years. And they had a really large population of people who had pre-COVID and post-COVID exercise tests. And what was really cool with this study is that we were able to look at both pre-pandemic controls as well as contemporary uninfected controls and compare those to the recovered controls and those with long COVID. So it was really powerful having multiple different control groups that we could compare to try to tease out how much of the decline in exercise capacity seen in a cross-sectional format is really attributable to COVID versus kind of some of the things that happened in our society during the pandemic. So what we actually found was quite surprising to us. we actually found that those who would go on to develop long COVID, shown here in the last set of bars on each of the panels, stratified here by sex, is that they had actually reduced exercise capacity even before they had COVID. So this was about 1 to 2 years before their index COVID infection. They actually had reduced exercise capacity even before they had COVID. So it's possible that this finding that we're observing across a lot of different studies is actually just that people with who are at higher risk of long COVID actually have reduced cardiorespiratory fitness. In other words, cardiorespiratory fitness is a risk factor for long COVID, not a result of long COVID. Now, there's a couple of caveats. There certainly are individuals who are elite athletes and no longer can exercise, but that's probably not the majority of people with long COVID. We were able to detect a difference among those infected, a difference in trajectory, but really minimal difference by long COVID status. So kind of shifting gears a little bit to another part of the story, my K-12 career development ward was really focused on, is there a difference in cardiopulmonary long COVID among people with HIV compared to people without HIV? So I got a Center for AIDS Research Mentored Scientist Award, and we did a small study investigating this with really 3 groups of people with HIV, those who are vaccinated and uninfected, those who recovered without symptoms, and those with long COVID, and compared those to our cohort that we had with people with and without long COVID. So before I go on to what we actually found in that study, I want to say why study cardiorespiratory fitness in HIV. The main reason is really that HIV is a powerful risk factor for cardiovascular disease, on the similar magnitude to diabetes, hypertension, obviously not as high prevalence, but a really powerful risk factor. And part of this is attributable to increased burden of traditional risk factors among people with HIV, things like dyslipidemia related to antiretroviral therapy, higher rates of smoking and stimulant use. But a large part of this has to do with immune dysregulation and inflammation. And I already kind of gave you a hint about the connection between inflammation and cardiorespiratory fitness. But this is the first reason to study it is because we don't really know fully why HIV increases risk, or the exact mechanisms of how inflammation actually leads to cardiovascular disease. And so I'll come to a little bit of a clinical paradigm. So when we're thinking about someone's cardiovascular risk, we often will use a calculator, things like the AHA pooled cohort equations, or now the PREVENT calculator. But the problem is when we try to do that with people with HIV, they have really poor calibration. They underpredict risk pretty dramatically. And they also have poor discrimination compared to the general population. They're not as good at distinguishing who has events. People have tried to incorporate HIV-specific markers, things like CD4 count, viral load, inflammation, exposure to really kind of dangerous antiretroviral therapy, and those haven't really improved these calculators. And this gives us a clue that there's something else going on. If we knew how to exactly the factors and we could just input those into the calculator, we probably would be better at predicting what's going to happen. So one of my ideas is maybe if we think about cardiorespiratory fitness, that might help us to understand risk a little better in a way that doesn't require radiation or contrast or things like that. The second reason why it's particularly interesting is this connection between heart failure and HIV. So what we found in our San Francisco heart failure cohort, among the 700 with HIV, they were 10 years younger at the time they were diagnosed with heart failure. They had more documented substance use. They had more heart failure with reduced ejection fraction, but not more coronary disease. And what's really interesting is that they had an increased risk of mortality, of 55% higher risk of mortality after they're diagnosed with heart failure compared to people without HIV. But they actually had lower risk of heart failure hospitalization, which we think is probably related to being better connected to care. This is similar to what we found in a national cohort study, the CNIX cohort, where most of the cardiomyopathy that was found in HIV is non-ischemic and related to how well their HIV disease is controlled, as well as traditional cardiovascular risk factors. Cardiorespiratory fitness is a powerful predictor of heart failure, and we don't really have good calculators to do that, even with the new PREVENT heart failure calculator. The third reason is because cardiorespiratory fitness is actually reduced in HIV. There's been 2 different systematic reviews and meta-analysis. This is from one of them. And then I really like this quote from the other one. Our meta-analysis demonstrates that people living with HIV should be considered as an important high-risk group for low cardiorespiratory fitness, an important predictor of cardiovascular disease and premature mortality. But the problem is we don't really know why. And we don't have targetable mechanisms to help address this risk factor. So back to our pilot study of cardiorespiratory fitness and HIV. Here's what we found. The people in blue here are the people with HIV in the three groups. And you can see that the three groups really are indistinguishable, both in their cardiorespiratory fitness as well as in their adjusted heart rate reserve. They have really profoundly abnormal chronotropy, even the people with HIV who didn't have COVID. So about a third of the people in our study had chronotropic incompetence, again, defined by a pretty strict criteria. This was really cool because very shortly after we published this, a study came out from Emory, led by Dr. Osler and Marconi, and it studied 74 people with HIV who are veterans in Atlanta without heart failure or coronary heart disease. And they also found that 31% had chronotropic incompetence. This came out just a few months after our paper. And then shortly thereafter, we were able to replicate this in another completely different cohort in Colorado called the Exercise for Healthy Aging study, which includes sedentary older people with HIV, and really found really consistent results across these three very different populations. The next question is it modifiable? Is it just a result of you have HIV, so you develop chronotropic incompetence? Well, in the Exercise for Healthy Aging study, which was an exercise study, after 12 weeks of exercise, we saw an increase both in chronotropy and in peak VO2. So these are basically the same exact line. And that was sustained after 24 weeks of exercise. So that led to my Career Development Award central hypothesis. The study is called Athlete HIV. And the idea is if we better understand chronotropic incompetence and cardiorespiratory fitness in HIV, it may help us to better understand mechanisms of cardiovascular disease in people with HIV and potentially even identify targetable ways we could intervene and prevent that. And these are probably most related to, again, this connection between chronic inflammation and chronotropic incompetence. So here's some preliminary data. People with HIV are known to have higher inflammatory markers, including IL-6. In our cohort, it was 1.7 versus 0.96 picograms per milliliter. You can see here this correlation between peak VO2 and also chronotropy and inflammatory markers in people with HIV. And then we were also able to replicate this in the Exercise for Healthy Aging study, where there's the higher your IL-6, the lower your adjusted heart rate reserve during exercise. So I just want to shift gears slightly to thinking about cardiopulmonary exercise testing, not just as a specific technique to understand biology in people, but also to start understanding the treatment effects. So the most obvious way that CPET is useful is to study how exercise impacts people. So this is a multi-center randomized clinical trial of a high-intensity interval training protocol versus continuous moderate intensity training, specifically for people with HIV. And this is building on that Exercise for Healthy Aging study that I mentioned. 118 people were randomized, half to each arm, and 110 of those had adequate quality CPETs. So what we found is that HIIT, high-intensity interval training, is associated with a greater increase in VO2 max, both on the absolute scale, which helps account for changes in body mass. So people obviously lose weight when they exercise, but also on the relative scale. And these findings, remember, this is not compared to no exercise. This is compared to a continuous moderate exercise program for 16 weeks. So this is to provide some evidence about what kind of exercise should we recommend to people with HIV. Thinking about CPET in other studies, so two of the other studies that I'm involved in, the CPET parts of are the HALO post-TB study, which is an NHLBI-funded observational cohort study in Uganda of post-TB heart and lung outcomes. So again, we don't really know what the impact of TB is on cardiorespiratory fitness. There's some data saying, based on 6-minute walk time, that we anticipate it will be reduced, but nobody's really looked at this connection with chronotropic incompetence. Post-TB heart and lung disease is really kind of an entity that's only been started to be studied in the last few years. So this is really exciting and kind of getting back to my global health roots that I shared in the beginning. And then the reverse long COVID clinical trial is studying baricitinib, which is a JAK-STAT inhibitor, again, testing this hypothesis that an immunomodulatory approach might impact cardiorespiratory fitness. Again, kind of testing in real people with long COVID, this biologic question of what is the impact of inflammation and the immune system on cardiorespiratory fitness. So with that, I'm going to share a couple of conclusions and then open things up for questions. So infections increase the risk of cardiovascular disease. For the sake of time, I didn't go into all the data showing all the different studies that show this. I just took it as a fact. But understanding how infections impact cardiovascular disease may provide insights into prevention and treatment strategies that are most relevant to people with those infections, but may extend beyond those infections themselves to understand human biology. The next thing is that I think that cardiopulmonary exercise testing is a really nice way to perturb biology so that we're not just assessing people at rest when many people are fine, kind of in normal homeostasis, but really have abnormal responses to stress. And this is a really precise and reproducible way to study that in live humans as opposed to animals. And then cardiopulmonary exercise testing can provide insights into the mechanisms of disease, their functional consequences, and assess potential treatment responses. So with that, I really want to thank all my mentors and sponsors, especially Priscilla Hsu for all of her mentorship over the years and for recruiting me to come here, and then my other mentors and collaborators, and also all of our research participants. So with that, I'm very happy to take any questions.
Matt, fantastic. Sorry, I was on Zoom, so I was tuning in for the first part of it. I may have missed this part, though. I think your story of the findings of the chronotropic incompetence in this population is super fascinating and curious in terms of like what we see a lot in our long COVID clinics. It feels like it's the opposite with a ton of POTS, orthostatic intolerance, and just a decent amount of objectively determined POTS physiology. So, like I know here you've identified maybe about a third of the people that this phenotype, but just curious like how you reconcile at least just the general experience where it seems like a good chunk of this population also has seemingly the opposite phenotype.
Yeah. So there's a couple of directions that could go in. One is, we were really interested in studying this more. So we did heads-up tilt table testing in a number of the people who had CPETs done. Some of them had chronotropic incompetence. We didn't specifically select for that, but we found that the people with chronotropic incompetence were actually more likely to have orthostatic hypotension. They were much more likely to have symptoms during their tilt table test. And they did have elevated resting heart rates that persisted throughout, but they didn't have a greater than 30 beat increase. Yeah. The second part of that is the abnormal response to kind of orthostatic changes in heart rate, like in POTS, probably does have something to do with inflammation as well. And it may be that it's a different response or different pathway that doesn't really necessarily affect their kind of maximal heart rate response. But what we did observe, and it's hard to distinguish on CPET, sometimes when you see an accelerated heart rate response, that can be a result of deconditioning. And what I didn't present here today is preliminary results from our Care Bearer pilot study of cardiac rehabilitation for people with long COVID. We're still analyzing the results, but some of those individuals have POTS as well. And they really have a really robust response to exercise and improvement in their heart rate response during exercise as well.
I guess Care Bear is probably the cutest trial name I've ever heard of.
Thank you.
But I mean, last year, Greg Lewis came and gave his talk on HFpEF phenotypes too, and like really fascinating that chronotropic incompetence seems to be a really important phenotype within the HFpEF world.
Yes.
So, seems to be some.
Again, it's a really powerful predictor of development of future HFpEF. And then among people with HFpEF, having chronotropic incompetence is really associated with much worse symptom burden, with reduced functional capacity and worse event outcomes. It's still really not well understood, the biology of why that happens. And some of the interesting studies in the HFpEF space have tested pacing as an example. Like, what if we just fix the heart rate?
Yeah.
And it actually doesn't help because you reduce the stroke volume. So the actual cardiac output and the peak VO2 does not increase when you pace someone with HFpEF. So that's why we're not testing pacemakers in people with long COVID to see if that'll help them feel better. It's really based on the kind of data from the HFpEF space. But there's other people who are working on HFpEF and chronotropic incompetence and trying to understand that biology.
That was a great talk, Matt. Sorry I missed the first part too. So not a science question, but just, we have so many fellows and trainees in the room. Do you have any kind of thoughts or advice for them just about a career in research?
Yeah.
I know your path has been strong, but I think lots of ups and downs too.
Yeah. I think a couple of things. One is, like, I originally had no plans to be in research, but it was fun, and I really enjoyed doing it, and getting to answer interesting questions, getting to work with really amazing teams of people to kind of think of what are the questions we want to try to answer, how do we actually answer them robustly and well. And I had this vision of, like, I want to be a global cardiologist, and with the COVID pandemic, with my having children, like, life took a little bit of a different journey, but I still was able to develop some really useful skills and then bring those back to work with the Uganda Heart Institute to try to study post-TB heart and lung disease. So I think, like, being willing to follow exciting side paths. And, if you had asked me, when I was starting my fellowship, what I would be doing now, I wouldn't have ever guessed this is what I would be doing. But it's just been a really fun journey. And a lot of that has to do with kind of, following interesting leads, finding good people to work with, and pursuing interesting questions.
I think for me, Matt taught me that mentorship is a bidirectional process. So I think, like, I knew Matt had this passion for global cardiology, and I know it's a shock, but I'm not someone who's like into roughing it. And so when he was like, to set up this collaboration in Uganda, I was going to have to go. And so I was like, ugh. But it turned out to be super rewarding, and I'm really grateful for that. So it just, it taught me that it's bidirectional. So I think working with Matt helped me expand what I was working on too, in a great way, in ways I never thought I'd be doing. So yeah, so those some crazy trips to Uganda, I'm gonna just say, but yeah, a great experience. And so I think, you've done amazing. So yeah, fantastic.
So now that you've identified, I guess, like a subgroup of individuals with this chronotropic incompetence, like, what are you doing in your next steps in terms of trying to molecularly define?
Yeah. I'm a clinical researcher. I'm not, like, in a wet lab, but we have great partners who have those kinds of skill sets. And a lot of what our team, kind of as a broader team, has focused on is testing mechanisms of disease through, like, small mechanistic clinical trials. So if we have this idea that it has to do with immunomodulation or the immune system, let's design a clinical trial to test that in humans, see what happens with the biology when we perturb that pathway that we think is affected. So that's kind of the concept of this reverse LC clinical trial. And that is not a straightforward or easy journey to go from this, we think this mechanism affects this disease, to, like, okay, we have to get funding. We have to find a team of people. This is like a 550 people, many centers now, originally started with 4 centers. And it's a huge amount of work to go from, like, this idea to, like, actually testing it. And then, like, on the other side of it, there are people who are testing, innovative markers, looking at viral persistence in the tissue. So actually collecting, like, gut biopsies of people with long COVID, some of whom have chronotropic incompetence, actually looking under the microscope for the virus, and then creating radioactive tracers to find the virus in the body. So kind of a more translational approach. And then, other parts of our team doing proteomics and other things to understand the pathways that are impacted. But it really comes back to being a team science approach.
And just as a random question, I know people exercise rodents all the time.
Yes.
Can you do CPAP on a rodent?
I am not Jeff is saying yes. You definitely can on like sheep, for example. With rodents, that you can definitely measure. You can do a CPAT on a rodent. I shouldn't have said I don't know the answer to that. What you can't really measure is chronotropic incompetence in a rodent. And it has to do with just how fast their heart rates are to begin with. So really the sheep are like the best animal model for chronotropic incompetence, and there's some elegant studies done in New Zealand under really assessing kind of how much of this chronotropic incompetence has to do with the parasympathetic or vagal response. They can sever the sheep's vagal nerves and see what happens. And what's really interesting is actually their research suggests that it's actually vagal tone actually increases during exercise, as opposed to what we traditionally think of as kind of withdrawal of vagal tone leading to that initial increase in heart rate. And so there's really, I'm not a sheep person. I'm glad there are people who are like really understanding those aspects of the biology and can do things. I can't like biopsy someone or, I can't cut someone's vagal nerve and see what happens. So it's really cool when those kind of stories can come together.
You mentioned there's the sex difference and the possible mechanism.
I'm not an expert on sex differences, but one hypothesis about this has to do with toll-like receptors, which are on the X chromosome, leading to differences in inflammatory responses. And so there's a lot of data showing, A, that these sex differences are real. Women are at more risk for developing long COVID. B, that there's very different kind of immune and inflammatory profiles during acute COVID that are related to biologic sex. And that probably impacts response to treatment as well. So metformin, for example, may be more useful in women with acute COVID, whereas kind of anti-inflammatory approaches, steroids may actually be more useful in men, kind of tamping down that acute inflammatory response.
Did you see that if a woman had more children, that affected their vulnerability, I guess, to this?
We haven't specifically looked at that. I think that one of the I took out the slide about kind of possible mechanisms of long COVID just for the sake of time, but there is one possible mechanism has to do with autoantibodies, and there's within our larger cohort, we can distinguish someone who had SARS-CoV-2 infection from someone who didn't by their antibody profile. But what we can't do is distinguish those with and without long COVID symptoms. And so it may be that there's like specific antibodies that lead to different phenotypes or subphenotypes, and so it's hard to kind of bucket them all together. But the idea that women who've had more children, they may have more sensitization, or may have a different autoantibody response. But our group hasn't specifically looked at that.
Hello, Matt. I have a question here on the Zoom. Thank you for your talk. And so I was intrigued by your data, where in addition to this abnormal cardiopulmonary testing and you're also seeing this decrease in the heart rate variability, and that's how you tied it up to autonomic dysregulation and increased sympathetic tone and so on. And at some point, so you also tied it with an endothelial dysfunction. So the question has to do is, and have you used any markers or any biomarkers to evaluate this endothelial dysfunction? And that's one question. And the second question is, so you show that it's not really that the people with the long COVID, or is that the people with long COVID already had this abnormal cardiopulmonary testing or chronotropic incompetence, and even before. However, these people feel really awful, right? So if the reason of why they feel so bad is the abnormal cardiopulmonary testing, it doesn't really make sense that you're just uncovering something that was present before. Maybe it is something that it was present before, true, but it made worse with the COVID, and you're not picking it up with the cardiopulmonary testing, and you will need something more sensitive to look at the difference in between before and after. Just a thought.
So I think I couldn't quite hear you in the beginning, but I think your first question was about endothelial dysfunction.
Yes, the first question is about if you have used any biomarkers and to evaluate that endothelial dysfunction that you are.
Yes. I didn't present that today. We actually just presented a study that we did with using the EndoPAT system, using peripheral arterial tonometry to assess endothelial function in people with long COVID compared to recovered controls. We had about 100 people in that study, and what we did not find any differences in endothelial function in that study. And when we looked at a few endothelial related biomarkers, and none of those have really shown any signal in our cohort. The second question I think was about kind of change from pre-COVID to post-COVID. In our specific study, we enrolled people after they had COVID. We didn't have pre-COVID testing results to say whether these things were present among individuals before. The only study where we have the pre and post is this really large cohort study. And there we did not detect a difference in heart rate response before and after COVID. And so it is possible that some of these individuals had some abnormal chronotropic response. Somehow the virus exacerbated it. But, I kind of share those as two separate stories, and they are kind of contradictory. And it's, that's how real life is in research.
Yeah, thank you.
Is the incidence of long COVID now? Is that changed?
Yeah.
Fewer cases, but the percentage that occur.
Yeah. If anybody didn't hear, the question was about the incidence of long COVID. So one of the things that I've learned how to do over my years of doing research now is we can't really randomize people to get infections. It's not really ethical. There were a few studies early in COVID of actually giving people COVID and seeing what happened, mostly in other countries, but it's not really ethical to randomize someone to get an infection. So I've learned how to use some more advanced observational approaches, things like target trial emulation, and some of our large, very large electronic cohort work suggests that yes, the incidence of long COVID is going down, and that probably has to do with both vaccination, evolution of the virus through its kind of different phenotypes to being less severe, and prior immunity from prior viral and prior COVID. So yes, the incidence is not zero. People still develop long COVID even from having COVID now, but it is much less common than it was in the earlier kind of initial waves of the virus.
Thank you. Thank you.